patients go to their doctor and say, I've got tinnitus, is there anything I can do? And the doctor says, no treatment for tinnitus. And that's simply not true. There's not one single treatment, that's true. But loads of people find several different types of treatments that are successful. And I think if we have a good education and handle on saying, okay, well, you might not benefit from this type of treatment, and we actually now know why you wouldn't benefit versus why someone else would benefit, but you will benefit from this treatment, then I think you're going to just, as you say, reduce stress in patients and have more clarity that, okay, it's not that it's the end of the road.
Today's guest on the Tinnitus Relief podcast is Dr. Joel Berger, PhD, researcher in auditory neuroscience. He's a musician and has experienced firsthand the power that sound can have on the brain. Joel's research focuses on objective testing for tinnitus, which will help us measure how tinnitus represents itself in the auditory brain. Joel is an assistant professor in the Department of Neurosurgery at the University of Iowa in the Human Brain Research Laboratory. Joel, welcome to the podcast. Please share your top insights on the importance of objective testing for tinnitus.
A lot of testing for tinnitus at the moment is primarily and solely done on subjective report in terms of different ways of doing that, and we can discuss some of those. That doesn't really get into measuring tinnitus in an observable way, and so I'm really thinking about the best way that we can actually individualize a test for tinnitus and measure someone's tinnitus to actually say, okay, this person has this frequency of tinnitus or this severity of tinnitus, and how we might do that, rather than necessarily, just looking and comparing people with and without tinnitus as a whole group.
Joel, as you were talking, I was thinking about the pitch of tinnitus and how for most people that is their first sort of online check of their tinnitus. They might think, oh, well, I want to know what pitch is this, or what sound am I even hearing? And on the screen right here, we have a graphic displayed through Audio Notch, which is essentially a tool that measures people's tinnitus pitch. There's not so much utility in terms of leading to treatment with this tool, but it is a way to measure tinnitus, and it is a subjective match, right? But I think that this is an example of a helpful subjective tool that people can relate to. Another one is the Tinnitus Functional Index. We'll put an image of that on the screen right now. That's an evidence-based questionnaire which touches on important key areas related to someone's quality of life, like sleep, intrusiveness, relaxation, sense of control, emotional distress, sound sensitivity, hearing, and it creates a score from 0 to 100 so that doctors, like we use this quite often, we can have a baseline level of tinnitus that is measured through this TFI, Tinnitus Functional Index score, and we measure tinnitus every 3 months during our program at Treble Health, and other tinnitus specialists hopefully do something similar. So ultimately, this does give us a lot to work with, but still we're lacking this objective measurement. So what is your group found in terms of the importance and really the next steps required to measure tinnitus objectively?
Yeah, so a lot of the ways that we look at objectively measuring tinnitus are through what we'd call electrophysiology, and some people might understand EEG, where you have a scalp cap that you wear on your head that's got a lot of electrodes on, measuring your brain activity. But there's also other flavors that might just involve one or two electrodes that would just go behind the ear and measure something that we've looked into called the post-auricular muscle, for instance. And so one thing that we've looked at doing is trying to, and this speaks to another reason you'd want an objective test for tinnitus, learning from the animal literature where we have behavioral models of tinnitus that we need. You can't ask an animal if it has tinnitus, you have an objective measure in an animal. And a common test there is called the gap detection test. And what this is that you have a continuous background sound, and if you play a sort of loud, short impulse sound, then you get a startle response in an animal, and it would happen in a human as well. You'd blink your face, and you'd also have a muscle behind your ear that would twitch. And the idea with this test in animals is that if you present a short gap in that continuous background sound just before that startling stimulus, then the animal, that kind of acts as an unconscious cue, and the animal reduces its response. And so you can tell that it's detected the gap. And the idea with tinnitus in animals, and it's been measured, it's the most commonly used measure in animals, is that if the animal then has tinnitus following noise exposure or giving some sort of drug, then when you have that gap, they won't reduce their startle as much. And so you can tell that they've got tinnitus because the continuous background sound that's similar to their tinnitus will not, when they have a gap in it, it won't reduce the startle as much.
And what kind of animals are typically tested that have the most close relationship to the human ear?
Well, so guinea pigs really have the most close, in terms of rodents and small animals, the closest system to us. So that's what we used to do in the UK. But a lot of mice and rats are used as well. There's a bit of a difficulty and problem there in that they have much higher frequency hearing. And so certainly in the group that I was in the UK, we preferred to use an animal that was closer to the human model, essentially. And so in animals, you have a nice thing where you can measure this before and after and really look within an animal as to whether they've experienced tinnitus following your intervention, if you like, and then give a drug and see whether that kind of eliminates their behavioural evidence of tinnitus. So we've we developed this test in guinea pigs where they would flick their ears, and humans sometimes can move their ears, sometimes not, but we have regardless of whether you can move your ears or not, we have a muscle here behind the ear called the postauricular muscle that still you can measure the potentials from. So you can still measure activity from this muscle. And so we attempted to kind of transfer this gap detection test in humans by recording just with a small electrode behind the ear when we're playing continuous noise, and then not an incredibly loud sound because, as you know, a lot of patients with tinnitus have hyperacusis, so that's something you want to avoid, a loud sound, but just even a moderate sound can cause a response in this muscle. And indeed, when you actually play a gap just before that sort of louder sound than the background, you can see that this muscle potential is reduced. So we had something that might possibly be a useful measure of at least gap detection, which you could then think of developing for a test in tinnitus patients. But then, in honesty, that led to issues where some tinnitus patients wouldn't actually have this muscle reflex. So then we weren't still at a point where we had a really reliable objective measure. And so I think there's definitely scope for that to be explored further, but we're not quite there, obviously, yet.
Hey guys, quick interruption from today's podcast. If you're dealing with the day-to-day stress of tinnitus and have been told there's not much you can do from other doctors, I want to let you know that we offer a free consultation with a specialist from Treble Health where we can discuss your tinnitus case and offer some potential solutions. See the link on the screen right there where you can book a free call and get help from a specialist who can take the next steps in finding relief. Click the link right there. Now, back to the podcast. So do you think an objective test for tinnitus would come from the muscles or the components around the ear, or do you think it would come from an image of the brain, for example, an MRI study?
Right, so I think I'm a neurophysiologist. I look at a lot of brain activity using MRIs, using EEG, and I think this is a very good way of doing it. I think whatever way we try to develop an objective test for tinnitus, we want something that can hopefully bridge between animal and human models. So in other words, ideally we have something that you could take into an animal and say, here we go, this would be able to measure tinnitus in an animal and it would also measure tinnitus in a human. And the reason you might want to do that is because there's a reasonable amount of animal research that's done to inform human research, but you want something that really bridges that gap between the two. And so I think a test probably using something like EEG or measuring muscle responses in a similar way to what we look at in animals is probably a good way to sort of be informed, at least.
When I think of measuring tinnitus through the brain or objective measurements, I think that there are other health conditions which probably have better objective tests than tinnitus, right? And tinnitus being so neurological in origin, is that why it makes it difficult? And I'm curious if there's other health conditions that have inspired your research into wondering, if this type of condition has that sort of test to measure it, maybe that could apply to tinnitus.
Right, yeah, I mean, when it comes to the difficulty in terms of measuring tinnitus, I think by its nature, unless we're talking about objective tinnitus, which obviously is a different kind of flavor. But when we're talking about subjective tinnitus, by its nature, it's subjective. So
Let's explain that for a bit. So subjective tinnitus is what 95% or more of people have. It means that the sound you're hearing is an internal sound coming from between the ear and the brain. If we put a little microphone next to your ear, we wouldn't register a sound, whereas objective tinnitus can potentially be picked up by a small microphone next to the eardrum or another part of your auditory system. So it's a physical object or a physiological sound that can be registered, correct?
exactly right. Yeah, that's it. And so when we're talking about that, sometimes there are often treatments for objective tinnitus in terms of, if there's some sort of vasculature or anything like that, there are potential treatments there. Whereas when it comes to subjective tinnitus, there's a lot of factors that can go into what's producing that and what's producing the response to that. And so that's where you get what we call heterogeneity, a lot of variability across different people. So some people might have a much louder tinnitus than someone else, and they're not at all bothered by it, whereas someone has a very low sensation level of their tinnitus, but they're extremely bothered by it. And of course, those are incredibly both valid cases, but there's probably very different things going on in those patients' brains. And so we really just need as a field in general to start thinking about, okay, how do we actually create something that's more individualized?
I think it's important. I want to touch on what you said, which is that someone can have a 3 out of 10 level of tinnitus, but it affects them 90% of their waking hours. Another person may report a 5 out of 10 tinnitus, and it's not that much of a problem for them. They only hear it occasionally, doesn't really impact their day-to-day life. The objective test would suggest perhaps that the 5 out of 10 person is worse, or that the 3 out of 10 person is better. Or perhaps the objective test would show us holistically, it's not simply the auditory cells in the brain that we're measuring here. It can be a holistic view of the emotional response, therefore the intensity of the nervous system and the reaction to tinnitus, because that is what matters. So how do you guys try to separate the objective nature versus the real world intensity or severity to people?
Yeah, so that's a very interesting point. And so some of the work that we've looked at doing in terms of, as I say, using this kind of gap detection model is to actually look at the best ways we can examine the actual percept. That is, what the sound level of the tinnitus is and what the frequency of tinnitus might be. But there's others going and taking a slightly different approach where it might be looking at how the response is. So, for instance, your frontal cortex of your brain might be responding differently because you're bothered by your tinnitus, whereas someone else who has a louder tinnitus but isn't so bothered has a different response in their frontal cortex. And in someone like that, you might say, okay, well then let's think of, different treatments like transcranial magnetic stimulation that's been tried for tinnitus. That might be effective in those patients that have, frontal cortex recruitment, but then other patients that have a louder tinnitus, there's a different type of treatment. So I really want to start getting towards where, as you say, we have a holistic view that for an individual patient, we understand what the severity of their tinnitus is in terms of the reaction, but also how loud their tinnitus is, the frequency of their tinnitus, and that sort of thing. And I think we're definitely not there as a field. I think it's potentially possible to get there, but it just requires a lot of individualization.
When everyone hears this, I want you to remember that this is a good thing, because individualization means you're going to get a better treatment outcome. When I see some products sold, for example, that are advertised or promised to help tinnitus, very generally speaking, and there's not much of a professional component to personalize it, I know it's not going to work for a majority of people, because that's just not how tinnitus works. You're alluding to that point, that there's various subtypes of tinnitus, various causes, right? It could be related to the hearing loss. It could be related to stress on the central nervous system. It could be related to TMJ, jaw, or cervical neck issues. It could be related to Meniere's disease or medication changes. Those are the 5 most common causes that our team sees amongst the literature and the research. it must be stated again that the treatments for each of those are different and should be personalized, but hopefully that's a motivating and encouraging thing to the listeners.
Yeah, completely. I mean, I think people like yourselves and others that are really actually focusing on, historically, when I started my PhD as well, I think it was still happening, probably still happens now. Patients go to their doctor and say, I've got tinnitus, is there anything I can do? And the doctor says, no treatment for tinnitus. And that's simply not true. There's not one single treatment, that's true. But loads of people find several different types of treatments that are successful. And I think if we have a good education and handle on saying, okay, well, you might not benefit from this type of treatment, and we actually now know why you wouldn't benefit versus why someone else would benefit, but you will benefit from this treatment, then I think you're going to just, as you say, reduce stress in patients and have more clarity that, okay, it's not that it's the end of the road if you try this one treatment that seems to be successful for some people, because there are other ways that, other treatments that can work.
All right, so Joel, you're an auditory neuroscientist, very familiar with the brain. I thought it would be educational for me to ask, could you explain in your own terms, where does tinnitus come from in the brain, and what brain regions are involved with bothersome, intense tinnitus?
It's a very good question. So we know that tinnitus is quite commonly associated with at least reduced output from the cochlea, so reduced output from what we call the peripheral hearing organ. Even when there's normal hearing, if you like, there might be some reduced output from there. And then when you go up into the auditory system, so there's different levels. There's a midbrain area called the inferior colliculus, and then we have the auditory cortex, which is sort of the main cortical center for auditory cognition. That's when you start to see areas of compensation. And I should say, actually, there's work done by Susan Shaw and others that even further down the system, like straight away after in what we call the cochlear nucleus, you see changes once you see a reduction in the output from the cochlea. And so the idea is that your brain is doing something to compensate for the fact that you've got some reduced output. And how it does that is still up in the air. It seems certainly that it increases the firing of neurons in these different brain regions, but that might not be sufficient to explain why you have tinnitus. So there might be then other areas, for instance, people that have somatosensory tinnitus, where they can modulate their tinnitus with their jaw. They might have some input from the somatosensory system to the cochlear nucleus that then, creates this perfect storm when you've got this reduced output from the cochlea. And again, this kind of highlights that there's not one single cause of tinnitus.
I certainly am working hard with my team at Treble Health to identify the different subtypes and root causes of tinnitus for the individual, and not look at a group and say, oh, they all have tinnitus, they should all be doing this system. That personalization is key for individuals who want to start that on their own. They can pick up on what we're talking about here, and they can look into, okay, do I have anything going on with my jaw? Do I have anything going on with my neck? That's somatic tinnitus. Have I, in the 3 to 6 months leading up to the beginning of bothersome tinnitus, was my life really stressful? Was I going through a lot? Was I going through another health condition that might have led to stress on the body, stress in the nervous system? We would call that the central subtype, or stress-induced tinnitus. And then, have I gotten a hearing test yet? Even if I don't have day-to-day problems with my hearing, did the hearing test show some hearing loss, most often a high-pitch hearing loss? Even if the standard hearing test was considered normal, there may be some changes that have happened at a cellular level over the years, and that could lead to cochlear tinnitus as well. So I agree with you that this type of focus will empower patients. It will increase the effectiveness of treatments from providers and audiologists who are helping our community here. I think that's super important, and I'm really glad to know that you're an ally in this work. On that note, could you share with us some of your research at the University of Iowa? What are you guys working on so that we can follow along and perhaps support as well?
Yeah, absolutely. So I do various research. One of my primary roles actually is in the Department of Neurosurgery. So I do a lot of research with patients with epilepsy that come in and have electrodes put in their brain to localize seizures. And these are amazing patients that are really willing to do research with us at the same time. And so a lot of this isn't necessarily tinnitus related, but a while back now we had one patient who came in and had epilepsy, came in to have these electrodes put in their brain to localize where their seizures were coming from to hopefully eliminate their epilepsy. And they also reported experiencing tinnitus, and intermittently as well. So with this patient, and as I say, they come in for a period of time for up to 2 weeks, and they're very willing to do research with us. And so with this patient, we were able to get them on a day when they had tinnitus, and also on days when they weren't experiencing tinnitus as well. And so, as I mentioned with the gap detection task earlier, we actually did this same thing where we presented them with these sounds, some of which had a short gap just before a short impulse that was not too loud so that it wasn't to be disturbing. And we were able to record from electrodes in their brain and find that on the day when they had tinnitus, at the frequency where they estimated that their tinnitus was, we actually saw reduced gap detection. And so it suggested that, like in the animals, they were actually experiencing this impairment of their gap detection, which is excellent in the sense of it being an objective measurement of their tinnitus. And thankfully for them, their tinnitus was intermittent. So on the days when they didn't have tinnitus, we could measure this same response and find that actually, they could show this reduction in the response of their brain when there was a gap presented just before this short impulse. So we had this very nice within individual person measurement of tinnitus versus no tinnitus in their brain, and this is a very unique scenario in which to do this. And of course, it's very important to state that I'm not suggesting we start implanting people with electrodes tinnitus, but more that this starts to inform us about ways that we might then think about looking at this, what we'd call non-invasively. So then we're thinking now in terms of, okay, could we now put electrodes on someone's scalp and then measure this, and ideally, again, get people that have tinnitus intermittently and get them on days when they have their tinnitus and when they don't, and see if we can measure within a person markers that would actually indicate that their tinnitus was present that day and it wasn't on another day.
Excellent. And do you have any other research focusing on tinnitus, or any other trends from colleagues that you're following closely that we can know as we bring our podcast home here?
Yeah, so I'm working with a group in the UK in Nottingham and at King's College London on potential drug treatments for tinnitus. And we've got a drug, there's Peter McNaughton and Mark Wallace and Alan Palmer in the UK that I'm working with. We've got a drug that seems to be successful in animals, at least in reducing behavioural signs of tinnitus. So that's one aspect. And then working with a group here with Rich Tyler, Phil Gander, and then also Will Sedley in the UK, we've been applying for funding to look at whether there are certain drugs that have been tested for tinnitus in humans that in some ways may be useful and effective in some patients, and trying to understand, okay, these are the patients that would benefit from that drug and others that wouldn't. So that's some of the work I'm doing, and also otherwise working with another group trying to understand how tinnitus relates to speech and noise understanding as well.
Excellent. Dr. Joel Berger, thank you so much. We support what you're doing. Please keep doing it. And if you found this podcast helpful, please comment on YouTube helpful. Joel, thanks again.
Thank you so much, man.
Hey guys, I hope you enjoyed today's podcast. If you'd like to work with a specialist on our team at Treble Health and get some questions answered about your specific case, click the link on the screen right there where you can book a free call. In this discovery call, you'll learn the next steps needed to find help, and whether that's with our team in our program or another referral to a specialist, we're going to take this next step very seriously for you. So click the link right there, and we'll see you at the call.